eventually cardiac dysfunction. Let's look at autopsy findings in congestive heart failure. Not surprising. I said it before. The heart's enlarged. All the chambers are enlarged. They're thickened. The chambers are dilated as well. It's almost a knee-jerk reflex when you do an autopsy on an older person to just say, you know, cardiac hypertrophy and dilatation. It's almost like present all the time, because you do autopsies on people that die of chronic diseases. You don't do autopsies on people that die acutely, like a gunshot wound to the head. Those are the properties of the medical examiners. And I want to show you something very important histologically as well, is that these fibers, if you actually measure them, they are bigger. And not only is the cytoplasm of the cardiac muscle cell or the cardiac muscle fiber thicker and bigger, but so is the nucleus. For some reason, both the cytoplasm and the nucleus of the myocytes, the myocardials, are bigger. And not only are the nucleus bigger, but it tends to be squared off. You see how you would normally think of a nucleus as being kind of oval or round or potato-shaped, but they talk about the boxcar effect of nuclei that are in hypertrophied cardiac muscle fibers. They generally look like they're kind of squared off as well as being bigger. So if you hear the word boxcar in histopathology, they're probably talking about myocardial hypertrophy. Let's talk about heart failure with respect to left and right sides. It's not too often that when a heart fails, it purely fails on the left side or it purely fails on the right side. Usually it's both sides, sometimes one more than the other. But when you look at the symptoms of what happens with left or right, just think of your anatomy. A primary left-sided heart failure would head back up into the lungs, right? A primary right-sided heart failure would have back up into the systemic circulation. So left-sided heart failure symptoms are basically significant congestion in the lungs, chronic. Remember, with chronic, you might see heart failure cells or hemosiderin-laden macrophages. Because of poor perfusion to the kidneys, you're going to get salt and fluid retention. And of course, eventually, you know, the last critical organ to fail is usual, the brain. So the primary symptoms of left heart failure are shortness of breath because of the pulmonary congestion, even to the point where people will require more and more pillows at night. Finally, no matter how they get, they're still getting short of breath at night. And there's a symptom called paroxysmal nocturnal dyspnea. You know, maybe you know somebody who had it, where they get extremely short of breath for no reason in the middle of their sleep. You know, normally if you're running a marathon, you can get short of breath. But when you're getting short of breath in the middle of your sleep, you know, that's probably a severe heart problem. Here's a summary: left heart failure, dyspnea, orthopnea, PND, blood-tinged sputum. Why? Because the lungs are so congested, they're actually extravasating red cells and later on hemosiderin into the sputum. Cyanosis because of inadequate. And when you do a catheterization on a person with primarily left heart failure, you'd expect the elevated venous pressure to be elevated because that's what's being backed up, and that's what they call the PCWP, or pulmonary wedge pressure. Okay, let's move to the other side of the heart now and talk about right-sided heart failure. In right-sided heart failure, if the myocardium fails for the right, often due to increased work demands on the right side of the heart or pulmonary hypertension, the primary backup is going to be systemically, anatomically speaking. So you have congested liver, congested spleen, congested kidneys, a lot of pitting edema in the extremities. So when you hear somebody having a lot of congestion in the liver, significant, that would be more of a right-sided heart failure thing rather than a left. These are all things that you can find. Here we go. Here's a little thing. And now the increased venous pressure is not going to be in the pulmonary side, but it's going to be in the systemic side. So they'll put in CVP catheters and look to see if the pressure in the systemic veins are elevated. And that's basically one good way of monitoring right heart failure. So here we go. There's a chest x-ray with pulmonary edema. I showed you before. Here it is with these hemosiderin latent macrophages within the alveoli. You know this is chronic. Here's a liver that's extremely congested. And remember, if a liver is extremely congested and prolonged, it could result not only in a necrosis in the central parts of the lobules, but eventually cirrhosis. So the concept of cardiac cirrhosis means there's been so much extreme congestion in that liver that eventually it has caused significant damage, leading to liver failure as well. So we talked about now, we didn't talk about the 5 different types of heart diseases. I guess you could say sort of anatomically classified, but not exactly. These are classically the 5 main categories: congenital, ischemic, hypertensive, valvular, and primary muscle failure, what they call myopathic heart disease or cardiomyopathies, or simply speaking, myopathy. So let's talk about congenital. We're going to do a lot on congenital, and let's try to group it into a sane organization. As you could guess, the earlier in embryogenesis, even as early as 3 weeks, is when you can have a critical significant problems in teratogenesis. So faulty embryogenesis in the 3rd to the 8th week, which is very early in pregnancy, are classic where we get the beginning of congenital heart defects. Usually they're monomorphic. In other words, it's only one single lesion. Sometimes you get a variety of lesions. And often the reason why you get a variety of lesions is because if one single lesion is incompatible with life, then you have to develop other lesions like shunts, for example, to make up for that. So when you have a non-monomorphic congenital heart defect, it's usually life-saving. Another thing is that some of the congenital things may not be evident until adult life, like coarctation, an atrial septal defect. The overall incidence is 1%, which is high. And remember when we showed you that chapter on congenital defects in chapter 10, I think it was, we said that a VSD, ASD, and clubfoot were the 3 most common defects. Well, both number 2 and number 3 were cardiac. And even though they're the most common, they're still only 1%. And of course, they can be detected so easily now with ultrasound and other methods. And it's really, really non-invasive methods are very, very good. Even intrauterine, especially with ultrasound and so forth, to detect these lesions. Look at the most common ones. I got those in red. And isn't it funny? You're probably wondering why I have a lot of black D's and blue T's. And I'll tell you why. Because this is the best way to remember congenital heart disease. If the disease has a D in its name, like ventricular septal defect or atrial septal defect or patent ductus or atrial ventricular septal defect, it's going to result as a left to right shunt or shunting from the systemic side into the pulmonary side. On the other hand, if you have a defect that has a T in its name, of which tetralogy is without a doubt the most common, but transposition of great arteries, truncus arteriosus, total anomalous pulmonary venous connection, and these are all cases in where you're going to have right to left shunting. And therefore, the babies will be blue because in the process of right to left shunting, it bypasses the lung, so the blood doesn't get oxygenated. So keep that in mind. D means left to right. T means right to left. And let's look at some of the genetic basis. We've already told you in the genetics chapter in pediatrics that trisomies, especially trisomy 21, Down syndrome, you see a variety of congenital heart defects. You can only find genetic abnormalities in 10%, so you know that they're probably developmental problems rather than purely genetic problems. There's a whole bunch of genes you might want to remember. I can never recall these offhand, which encode for transcription factors, which when they're mutated will result in diseases. And if you remember, we talked about the velococardiofacial syndrome or deletion of the long arm of chromosome 22, that resulted in a variety of cardiac and facial deformities as well. So these are generally the genetic factors of. Environmental maternal infections with rubella especially has resulted in a variety of child cardiac defects and the subject of teratogens in general. So let's talk about congenital heart disease. We've already said that with left to right shunts, they have all D's in their names, and there's no cyanosis. Why? Because you're shunting from the left to the right side. But the biggest feared consequence of shunting from the left to the right side is pulmonary hypertension, because you're introducing that systemic pressure to the pulmonary side. And pulmonary hypertension is the greatest feared consequence, because if it's very significant, even if you correct it, it's irreversible. Your lungs are already terminally damaged. The baby will die. And right to left shunts, when you think about it, the lungs are being bypassed, so the babies are blue. So the blue babies have all T's in their names, don't they? And of course, think about it. If you have a venous emboli and you're doing right to left shunting, then the venous emboli are not going to go in the lung. They're going to go directly into the systemic circulation, aren't they? And then the third class of congenital heart disease are obstructions, like coarctations, atresias. Here's the left to the right ones, all the D's. They're generally non-cyanotic. We said pulmonary hypertension is the most feared consequence. And here's a little diagram. In ASD, you have a little hole between the two atria. In VSD, you have a little or a big hole between the two ventricles. In PDA, you have the persistence of the ductus arteriosus, which you know should normally close very soon with respect to the time of birth, usually within minutes or hours. It can stay open even into adult life. It has a horrible murmur generally. Or if you have a very significant hole that involves both rights at the atrial and ventricular level, you could have almost a common single chamber for the heart, can't you? In addition, here's a large VSD. And remember, if there's a large VSD, you're introducing systemic pressure into the lungs. And therefore, if you damage those lungs enough, it's uncorrectable. ASD is usually at the fossa ovalis level. Remember, in the fossa ovalis, you found that thin little membrane between the atria, and 90% of the ASDs are just defective closing of that. There is something called a primum as well as a sinus venosus, which are a little bigger and a lot rarer, and they can also contribute to defects or hole between the two atria. VSD, which is classically the most common congenital heart defect, only 30% of them are isolated, and the reason why most of them are not isolated is because when you have a VSD, you have to have other anatomic features in the heart to compensate for it. So that's why most of them are not isolated. 90% of them involve the membranous septum, which is the membranous or fibrous part of the septum. It's not too often involves the actual muscular part of the septum. But if it does, it's more likely to be multiple. And if it's a small one, it often closes spontaneously because of pressure differences. But if it's a large one, think about it. You're introducing systemic pressures into the lungs. In other words, pulmonary hypertension, right heart failure, cor pulmonale. Here's a classical hole in the ventricle in the septum membranaceum. Remember, this is the membranous part. That's why it looks white. It's not in the muscular part down here. In a patent ductus arteriosus, most of them are isolated. They have a pretty harsh murmur, and as you would guess, it's a left to right shunt because you're going from a higher pressure thing in the aorta to a lower pressure thing in the pulmonary artery. But if it's big, you can get pulmonary hypertension. So closing that defect can be life-saving. And sometimes keeping it open may be life-saving. And why is that? The reason why that is because that patient may have to have that defect because of other cardiac anomalies. Because if it didn't have it, it would be incompatible with life. Think about it physiologically. You'll figure it out. Here's a big defect involving both at the atrial and ventricular level, the atrial ventricular septal defect. And if it's really big, you could think of a heart in which all four chambers freely communicate. Serious problem. Let's look at the right to left shunts now, the blue babies. They all have T's in their name. By far, tetralogy of Fallot is the biggest one. That's why I'm going to increase its font size right now. The rest of them are all possible, but in every case here, you have right to left shunting. They could be minimal, but if it's big, the baby's going to be blue, isn't it? So in a right to left shunt with the tetralogy, here are the 4 things as to why it's called tetralogy. Well, there's a big ventricular septal defect, and therefore obstruction to right ventricular flow. The aorta overrides the ventricular septal defect, and you have right ventricular hypertrophy. Why? Because there's so much increased pressure in that right ventricle. So these can be mild, and if they're mild, they're not even really blue. They call them pink tetralogies. But if they're severe, it could be a very, very bad survival. I hate doing stuff like this without showing you a picture, so let's look at it. Here you go. You have this big ventricular septal defect, and therefore obstruction to right ventricular flow. Most of the stuff's going through the defect rather than the pulmonary artery, and the aorta overrides the defect. So here's the aorta, and it's actually overriding this defect. And because now you have systemic pressure, or almost, in the right ventricle, look at that real thick RVH. Or if you just want to remember the tetralogy as those 4 things mechanically, you can, but it's better if you think of it physiologically. Either way, it's I hate to say this, I really find myself hating to say this, but it's a real favorite board question. Transposition of great arteries is exactly what you think. The aorta is where the pulmonary artery should be, and vice versa. So think about it. If you have a situation like that, you actually have to have a shunt to survive, don't you? Most of the shunts are patent ductus shunt or patent foramen ovale. And these are unstable shunts. Why? Because they close normally, remember? So if a person has a VSD, which is present in about 1/3 of the cases, that's more of a stable shunt because VSDs don't normally close. And because it is a significant shunt, your right ventricle is often thicker than your left ventricle, like you see here. Usually it's the other way around. And of course, the surgical thing is to switch them. And it's very, very, very serious disease. If it's not corrected, it's usually fatal very early in life. Here's a truncus, and a truncus is a big outflow vessel that has both the aorta and the pulmonary artery as its outflow tract. So as you would guess, there has to be a shunt here too, and we have a big septal defect. And in addition, what can we say about truncus? Do we want to say anything about truncus? No, we'll just define it. Okay, here's a tricuspid atresia. We define atresia as something that is blocked. It doesn't get through. You don't have any patency of the tricuspid valve. Therefore, the right ventricle is hypoplastic. And think about it. That patient needs a shunt to survive too, don't they? It's a very, very serious disease, a very, very high mortality. Margaret, are you still with me, please?
I'm here.
Okay, would you do me a favor, and would you add somebody to our thing here?
I see Henry, but I'm not sure if he added my details, so I'm not sure I can, but I'll try.
Well, Henry.Zeidan, Zeidan. Otherwise, I'm going to just zap them and have them quit bothering me. Okay. Give it a try anyway.
I'll try.
Okay, also, once he gets on, I'll give him the URL again.
Okay.
Which is that. Okay, let's go into... We talked about, here's another T1, the total anomalous pulmonary. So there's shunting. And the definition of total anomalous pulmonary venous connection is the pulmonary veins don't normally go into the left atrium, but they go into left innominate or on the other side of the heart. So think about it. If you have a situation like this, you need a shunt also, don't you? So these patients usually have either a patent foramen ovale or a VSD. And because of this, they also have a very hypoplastic left atrium. Why? Because there's no pulmonary veins going into them. Let's talk about, now that we mentioned all of the left to right and right to left shunts. And what happens, let's talk about the simple concept of obstruction. If you aorta is coarctated or compressed, you know, that's a common one. By the same token, your pulmonary artery can be coarctated or stenotic, or what they call pulmonary stenosis, or in the severe form, atresia. And once again, the aorta can as well. So most of the congenital heart diseases, which are in the obstructive category, are either at the aortic or pulmonary artery level. And here we go, coarctation of the aorta, much more common in males. The infantile form is very serious. The adult form is associated with a closed ductus, and for some reason, when you have a coarctated aorta, I haven't thought about this, maybe there's a physiologic reason, but that aortic valve is bicuspid about half of the time. So are you expected to remember that? I don't know. I barely remember it myself. Let's talk about pulmonic stenosis. If your pulmonary artery is severely stenotic or 100% atretic, in other words, doesn't work, you have a hypoplastic right ventricle. Why? Because there's nothing to pump blood into that pulmonary artery. So it doesn't have to have any thickness to it or volume. And it's usually associated with the ASD, and the clinical severity of disease is directly proportional to the severity of the stenosis. That should make sense. Last one, aortic stenosis, atresia. You can have stenosis of the aorta either above the valve, at the valve, or below the valve. Okay, that's how they classify it. If it's a severe valvular problem, think about it. You have a hypoplastic left ventricle, very, very high fatality. If it's below the valve, you're going to have an aortic wall very thick below the cusps, much, much thicker than above the cups. And if it's above the valve, you can have an aortic wall thick above the cusps. Why? Because that's where the stenosis or the atresia is going to be. Hopefully that makes sense. We're done with congenital heart disease. It was a big, big, big thing. It's about as big as any. It means we're almost halfway done. I want to do, you know what I want to do right now? It's early. I want to take only a 5-minute break and then tear out like a bat out of hell for the rest of the chapter here, because we can handle it. Because most of the ischemic stuff we've dealt with already on the previous chapter, and the rest of these topics are not terribly big. So, Margaret, are you still with me?
I'm with you.
It's 9:52.
Okay.
No later than 10 o'clock, give me a call, and we're going to have 1 hour of hell, and then we'll all feel good after that.
Okay, I'm synchronizing my back clock here. There we
It's
go.
9:52. I got internet time. Thank you, Margaret.
Okay. See
you. I'm going to play a little bit more Suzette, if you don't mind, during the 7-minute break.
Okay. All right, guys.